Good morning and welcome to this meeting on Mavacamten for hypertrophic cardiomyopathy, effectiveness and value. This is a meeting of the California Technology Assessment Forum convened by ICER, the Institute for Clinical and Economic Review. I'm Steve Pearson. We are going to be starting in approximately 1 minute to give people the chance to log in. Thank you.
Hello, everyone. Welcome everyone who's zooming in virtually to today's CTAF meeting, exploring the efficacy, safety, and an estimate of its cost effectiveness of a novel oral myosin inhibitor, Mavacamten, for the treatment and management of hypertrophic cardiomyopathy. My name is Ralph Brindis, and I'm acting as chair of the CTAF panel today. At this time, I will have our august CTAF members to briefly introduce themselves and declare any potential relationships or conflicts of interest. Dr. Cohn.
Good morning. I am Felicia Cohn. I'm the bioethics director for Kaiser Permanente in Orange County and a clinical professor at the University of California, Irvine School of Medicine. I have no conflicts of interest.
Robert Collier.
Click it. Hi, my name is Bob Collier. I'm a patient advocate with Patient Advocates and Research, working directly with researchers for 30 years now. I have no further conflicts of interest.
Dr. Gregory.
Good morning. I'm Kimberly Gregory. I'm Vice Chair for Women's Healthcare Quality and Performance Improvement at Cedars-Sinai Medical Center. I'm a professor in OBGYN and I have the School of Public Health at UCLA, and I have no conflicts of interest.
Dr. Heidenreich.
Hello, Paul Heidenreich. I'm a cardiologist and professor and vice chair for quality in the Department of Medicine at Stanford University School of Medicine.
Dr. Hoch.
Good morning, everyone. I'm Jeffrey Hotch. I'm the Associate Director for the Center for Healthcare Policy and Research, and I'm a professor of health economics. The Department of Public Health Sciences at the University of California at Davis. I have no conflicts of interest.
Dr. Lee.
My name is Sei Lee. I'm a professor of medicine in the Division of Geriatrics at UCSF. I have no conflicts of interest.
Dr. Melnikow.
I'm Joy Melnikow. I'm Professor Emeritus in the Department of Family and Community Medicine at University of California, Davis, and I have no conflicts of interest.
Dr. Murphy.
Hi, I'm an endocrinologist and a professor of medicine at UCSF and chief of the Division of Endocrinology at San Francisco General Hospital. I have no conflicts.
Dr. Phillips.
Good morning, everybody. Catherine Phillips, Professor of Health Economics, University of California, San Francisco.
Dr. Redbrick.
Good morning. I'm Rita Redbrick. I'm a cardiologist at the University of California, San Francisco, and I'm also director of our inquiry program for the medical students research requirement.
Richard Seiden.
Good morning. I'm Richard Seiden, a patient advocate, and I have no conflicts.
Dr. Smith. Alexander.
Hi, Alex Smith. I'm a palliative care physician and researcher and professor of medicine in the UCSF Division of Geriatrics, and I have no conflicts.
Joanna Smith.
Good morning. I'm Joanna Smith. I have an independent healthcare advocacy practice in Berkeley, California, and I have no conflicts of interest.
Anthony Sowery.
Good morning, everyone. My name is Tony Sowery. I am a patient advocate at NPAF from San Francisco. I have no conflicts of interest.
And Ralph Brindis, I am a clinical professor of medicine at UCSF and I have no conflicts of interest. At the beginning of every CTAF meeting, we want to ensure that all speakers disclose any financial relationships with industry. Every member of our CTAF panel is present today has met the ICER conflict of interest policy. And at this time, I would like to introduce each of these patient and clinical experts and as listed. But first, I would like to call on Dr. Desai.
Hello, everybody. Thank you for the invitation. I'm Desai. I'm a cardiologist, and I also direct our hypertrophic cardiomyopathy program at the Cleveland Clinic in Cleveland, Ohio. As it's relevant to this event, I am the principal investigator of VALOR HCM study, which is an ongoing trial testing the role of Mavacamten in hypertrophic cardiomyopathy patients, obstructive hypertrophic cardiomyopathy patients.
Dr. Maron.
Yep, good morning. Just want to start by saying, first of all, thank you. It's an honor to be part of this initiative, which is obviously very important for this disease and the patients. I'm the director for the Hypertrophic Cardiomyopathy Center at Tufts Medical Center, as well as the HCM Center at Morristown Medical Center in Morristown, New Jersey. My relevant conflicts would be site investigator for the phase 1 Mavacamten study, and also I'm the principal investigator for the phase 2 study Redwood HCM, evaluating the efficacy of a second generation myosin inhibitor sponsored by Cytokinetics. Again, thank you for the opportunity.
Thank you for being here. Gwen Mays.
Hi, good morning. My name is Gwen Mays. I'm currently an independent writer and healthcare consultant. You'll see on my disclosures that my clients do include the Hypertrophic Cardiomyopathy Association, as well as other patient advocacy organizations not relevant to today's program. I'm also a consultant with cardiac device companies, including Edwards Life Science and Paragonix Technologies.
Lisa Salberg.
Good morning, everybody, and thank you for being here. I am the founder and CEO, as well as board member to the Hypertrophic Cardiomyopathy Association. As such, that is my employer. My employer does receive funding from Bristol Myers Squibb Myocardia in the form of sponsorship, as well as, and it's not on this slide, we have sponsorship in the same level from Cytokinetics, which is also developing a myosin inhibitor. But that is for educational programming only, and trust me, it doesn't stop me from being critical of everybody. Thank you.
Thanks, Lisa. We'd also like to remind all speakers, other speakers who are, including those on the policy roundtable participants, and any individual making public comments, that they also should announce any financial relationships with industry or other potential influences on their judgment when they speak. We also wanted to let everyone know that we'll be presenting this information publicly on slides. I'd like now to introduce Dr. Stephen Pearson, who is the founder and president of the Institute for Clinical and Economic Review, or ICER. Steve is an internist, health services researcher, and ethicist who we can proudly say here in San Francisco received his medical degree at UCSF. Steve?
Thank you, Ralph. And good morning to, or now afternoon on the East Coast, but a welcome to all of you who are participating in today's meeting. We have a lot to do. And we like to start these meetings by kind of focusing on why we are here today. What is the purpose of this kind of public meeting? And it starts with the people living with the condition and the unmet need and the burden that the conditions can often create. So here's a quote from a person living with hypertrophic cardiomyopathy. HCM has a huge impact on my life, and it affects my job. I can't walk more than 10 minutes without stopping to catch my breath. I can't work out like I used to. I'm gaining weight. I can only walk up one flight of stairs at a time. I'm embarrassed to be around people who may see me struggling to breathe. It keeps me secluded in my home. And what's most depressing is seeing how I'm getting worse and can't stop it. So as we'll hear more from our team, from the patient experts and clinical experts, HCM is a condition around which a lot of clinicians have much to learn. And we all have much to learn, starting with the burden and the needs of patients and their families who are burdened and living with this condition. So we're here to focus on that. And one thing to ask ourselves is what happens the day that treatments like Mavacamten, and we are certainly expecting that will be approved by the FDA, what happens the day that they are approved? Well, pretty much the first thing is a sense of celebration, because now, again, patients and their families and their caregivers, clinicians have another option, have a new option, one that often can provide, again, different benefits or better benefits in many different ways. So the celebration accrues to that, and also to the fact that it often reflects years of investment by drug companies in the research. It involves the sweat of patient groups in helping to mobilize patients to participate in clinical trials and to help inform those trials. So there's a lot of reason to celebrate. The other thing that happens the day that a drug is approved is that patients can start to try to get the drug, but have difficulty doing so. They have to think about, is it going to be covered by my insurance company for me? And if it is, how much am I going to have to pay out of pocket for it? And more broadly, how much will it affect my overall healthcare insurance premium? So these issues start to arise for patients right away. The other thing that we're here for today is to keep in mind that not only the things decided about this drug around its price, its coverage, its use, influence and affect those patients, it also affects other patients and people in the healthcare system more broadly. And just to kind of put a face to this aspect, I have a slide that will give you 3 examples of people who wrestle with the impact that many people really do wrestle with, which is the overall cost of healthcare insurance and their out-of-pocket expenses. So the first gentleman on the left, Mr. Edlow, is a pharmacist by training, and has really spent much of his career bearing witness to the difficulties that his patients and his community in Virginia suffer from just trying to afford their health care. And again, that extends not just to the cost of the individual drugs, but to their health insurance. The Whitman family, and these were stories that are in the public domain, the Whitman family in Alaska was covered because they represent an unfortunately growing number of Americans who are self-employed and do not feel like they can afford insurance with the subsidies on the healthcare marketplace. So several years ago, they felt like they had to give up their health insurance. They just could not afford it on their income, even with the subsidies. And as a result, they described the stress that their family has gone through, worrying about the health, especially of their kids, and a couple of cases where they thought that the kids might have had a concussion, but they just didn't feel like they could take them into the emergency room or seek even primary care. So another reflection of the difficulties that many Americans face due to the overall cost of healthcare. And the last family on the right is a family in Minnesota that has had healthcare insurance all the way through. And their daughter, the daughter in the family, the woman with the hat on, has had a chronic condition that has been very expensive, leading to deductible expenses. And the McCoo family joins what has been recently shown to be over 25% of Americans who have a credit rating who are in collection with their medical debt. And that means that they're not just trying to pay it off, they're in collection and people are after them. And imagine a quarter of this country with a credit report. And some people estimate that that's over 20 million Americans are in medical debt and being sought after by collectors. So you can imagine that their life is one of great stress and concern because her ongoing healthcare costs are not going away. So all of these folks represent a picture of a spectrum of our communities around us. And so in a way, as we focus today, and as we should focus today on a world in which we want to talk about the best care for patients and their families with HCM and how we get that right, we are here today also because we want to remember that we may not see them directly, but around them are a group of families that represent our community. And we have to create a wholeness about this so that we can take care and keep our focus on that patient in the middle, while also representing the important needs and concerns of the broader community, who someday themselves will be that patient in the middle. So with that, let me give you an organizational overview, a bit of the background for today. You've met the members of the California Technology Assessment Forum, and it's August, I will use his word, chairman, Dr. Brindis. ICER, which is the convening host and the academic secretariat, is an independent research institute, and our sources of funding are kept updated on our website, where you can see the full pie chart of our funding. And you can see here that the majority of our research funding, or all of our research funding, comes from nonprofit foundations and a relatively small amount of government contracts and philanthropic donations. None of these foundations have direct ties to the healthcare industry. The largest single funder is the Laura and John Arnold Foundation. And we do take about 21% of our overall revenue directly from life science manufacturers and health plans and provider groups to support a separate policy summit program that produces policy papers and hosts meetings and webinars. So it's separate from the research that we do that goes into the reports and the meetings like the one today. So the report itself, that's, if you will, the backdrop to the discussion, is developed over about an 8-month period. And it starts with what we call scoping. And that's where we try very hard to admit that we don't know even what we don't know. So we reach out to patients and patient groups, to clinical experts, to the manufacturers, obviously, and other stakeholders to try to get our bearings and to understand what are the key issues around the evidence, what really matters most to patients in terms of the outcomes that are measured in the clinical trials or not measured in the clinical trials. We have to try to cast a very broad net. We do an internal analysis, this ICER staff in the lead of looking at whatever data we can get our hands on. In the published evidence, sometimes we can glean additional information from manufacturers and other sources. And we do, as part of our report, have a cost effectiveness model. In this case, it was done with outside collaboration from academic professors at the University of Illinois at Chicago. The report goes through several different cycles of public comment and revision. And at the end, we also benefit from expert reviewers, including the 4 folks shown here, the 2 clinical experts whom you've already met, Lisa Sahlberg, whom you've also met, and Dr. Steve Oman, who's also a clinical cardiologist who cares for patients with HCM. So the last thing I wanted to show as far as backdrop before we dive into the evidence itself is how the evidence itself, in a way, is conceptually structured in both the report and the way that we want to hold the conversation today. And this is linked to our value assessment framework. When we talk about things like value, it obviously can mean different things to different people. And even if we're talking about the same thing, it will look differently to different people based on their perspectives. But what we want to try to build is an understanding that it's a complex composite of different components. So for instance, a new drug, a new treatment might at the bottom here, as a first step, it might help us by helping us live longer. So the health benefits can include a longer life. It might do that, or it might help us by helping us return to better function or maintaining function and having fewer side effects than other options. Many different ways it can help us with the quality of life, not just with the length of that life. When we talk about value in our reports, we are looking at the overall costs inside the healthcare system, and where possible, we also look at costs outside the healthcare system. But this certainly means that we are not focusing just on the cost of a drug and other drugs. We're looking at hospital costs, doctor costs, procedure costs, everything we can try to wrap in to create a more comprehensive view. And then the 2 kind of rectangles in blue represent things that are sometimes hard to get data on, but that by that feature that does not make them in many ways or in any way less important. So we are going to be talking about the health benefits, but we'll also be talking and voting on potential benefits that extend even beyond what we might consider to be the health of the patient. And things like how it affects the families, prospects for work, education, et cetera. And then we also want to keep in mind special social or ethical priorities that can be linked to things like the severity of the condition, the effects that it might have on health inequities, and our ability, again, to kind of view the health gains in a broader context of what our society hopes to achieve. So this is the broader framework around value that our report is intended to help inform. We hope to have a very broad discussion around this as part of the meeting today. And we'll kick off with my handing it over. We'll kick off with my showing you the agenda, which is just to show you again the course of the day through 6 hours. We'll start with the clinical evidence, then the economic evidence. A lot of chance there for questions from the CTAF panel. And then we'll move into public comments discussion, a short break followed by deliberation and voting by the CTAF panel. And then following the lunch, we'll come back for a policy roundtable at which we'll have patient experts, clinical experts, payers. Unfortunately, we usually have the manufacturer, but they have chosen not to participate. And the goal is to talk about how we do this right going forward, how we build that healthcare system around pricing, around access, around decision-making, and future research in a way to do the best job we can for patients today and for that broader community that we need to keep in mind. So that will conclude with reflections from the CTAF panel and the adjournment at 3 p.m. Pacific time. And with that, I will now hand it over to Dr. Jason Waspi, who is the lead evidence author on this report. Dr. Waspi, take us away.
Thank you so much, Steve. My name is Jason Waspi. I'm an associate professor at Harvard Medical School, and I'm a clinical cardiologist at Massachusetts General Hospital. Next slide, please. I had the great privilege to lead this research team alongside an amazing ICER staff, Molly Beinfeld and Emily Nahn. None of us have conflicts of interest in the ICER definition. I also wanted to thank the clinical experts who have provided so much wonderful input and the patients who really have infused our report with so much rich knowledge and meaning. Next slide. Hypertrophic cardiomyopathy is a genetic disorder that involves heart muscle. It causes dysfunctioning and thickening of the ventricle. Hypertrophic obstructive cardiomyopathy is a subtype of hypertrophic cardiomyopathy in which that thickening leads to narrowing and obstruction in the left ventricular outflow tract, which is the main conduit through which blood exits the heart. In this situation, the narrowing causes a pressure drop in the LVOT, the left ventricular outflow tract, which can lead to symptoms including shortness of breath and chest discomfort with exertion. So in this type of situation, reducing the magnitude of that hemodynamic gradient is a core goal of therapy. Patients have other symptoms like palpitations, dizziness, syncope or fainting. Atrial fibrillation, irregular heart rhythms from the atria are often poorly tolerated for patients with HCM. And it's important to remember that many patients with HCM, obstructive and non-obstructive, can also have other types of symptoms related to other causes like diastolic dysfunction or microvascular angina. Next slide, please. It's important to distinguish HCM in clinical practice from other types of hypertrophy like hypertensive heart disease or infiltrative disorders such as amyloidosis or athlete's heart, which is a variant. It's not a disease condition; it's a variant of normal. And so, perhaps in that setting where screening and differences matter so much, the true prevalence of HCM is unknown. For example, in community-based studies, maybe 1 in 500 when echocardiography is used to screen, but much more prevalent if cardiac MRI is used to screen. There is a risk of sudden cardiac death with appropriate use of implantable cardioverter defibrillators in real-world practice. The rate of sudden cardiac death has declined to 0.5% per patient year. Next slide. The key to understanding the pathophysiology is that hypertrophic cardiomyopathy really can present in a very diverse way. The shape of the hypertrophy can vary, and it really is the variants where there's more hypertrophy in the region of the left ventricular outflow tract. Those are the patients that are at most at risk of having this subtype of hypertrophic cardiomyopathy, hypertrophic obstructive cardiomyopathy. Next slide. The 2020 guidelines were recently published. This was the first guideline revision in 9 years. And so for this subtype of HCM, when patients have obstruction and symptoms, there's a pretty clear management algorithm. So to avoid vasodilators and high-dose diuretics because these patients' physiology tends to be so loading dependent. The first line is beta blockade and calcium channel blockers. If they're persistent exertional symptoms, you sort of have two options. Disopyramide, which is a repurposed antiarrhythmic that has negative inotropic properties, or septal reduction therapies. That includes surgical myomectomy, which is open heart surgery, or alcohol septal ablation, which is a percutaneous procedure that doesn't involve surgery. Next slide, please. The way that the mechanical septal reduction procedures work, this is an example of surgical myectomy, is that there literally is open heart surgery and you remove the area of heart muscle that's causing hemodynamic obstruction in the left ventricular outflow tract. I don't show it here, but percutaneous septal ablation sort of uses the same principles, which is injection of alcohol into a septal perforator artery, which causes tissue death in the same area. So literally is an attempt to remove the tissue that's causing obstruction. Next slide, please. The main therapy under review in this setting is mavacamten. It's an oral first-in-class inhibitor of cardiac myosin. The PDUFA date is January 2022, so we expect a decision from the FDA soon. The comparators were informed by input from patients that they were directly referent to the ACC/AHA guidelines and the therapies that are referenced there, and also subject to feedback from clinical experts and public commentary like editorials in medical journals. They included usual care, which we define as beta blockers and calcium channel blockers, disopyramide, percutaneous septal ablation, and surgical myectomy. Next slide. The scope of the review includes patients with symptomatic hypertrophic obstructive cardiomyopathy, and outcomes that we included evidence on, including functional status, health-related quality of life, including patient-reported outcomes, different echocardiographic parameters, peak oxygen consumption, and also serum cardiac biomarkers. Next slide. In terms of we had a lot of discussions with patients and patient advocates. And so we in a part of our sort of early ICER scoping process, we have questions that we ask of patients, and the Hypertrophic Cardiomyopathy Association actually sent the questions out to many patients, and we got this tremendous richness of detailed responses, and we attempted to do qualitative coding to sort of draw out common themes from these responses. And a lot of common themes were side effects of beta blockers. That this is a known thing in clinical cardiology. There are a lot of side effects of beta blockers that are bothersome to patients. There are a lot of difficulty accessing treatment. The centers of excellence are actually explicitly in the ACC/AHA guidelines, yet many patients don't have great access to these centers of excellence. There's also a known drug shortage of the long-acting form of disopyramide. There are a lot of impacts of both symptoms and the side effects of current therapies on things like work, education, family, and relationships. Often people are having hypertrophic cardiomyopathy symptoms at the same key times in their lives that they're making decisions about whether to have a family or whether to go to grad school or those sorts of key life decisions. And there's clearly an unmet need. Only about 50% of patients say that the treatments work well. Next slide. In terms of the clinical evidence informing this review, the main data that we use for mavacamten is a phase 3 trial called Explorer, which randomized mavacamten against usual care as defined by beta blockers and calcium channel blockers. And at 30 weeks, the primary endpoint of the trial was an increase of 1.5 milliliters per kilogram in peak VO2, and a clinician-defined symptom improvement of 1 New York Heart Association class, which is a measure of clinician-assessed functional status and heart failure, or, this was another part of the composite and the primary endpoint, an increase of 3.0 milliliters per kilogram improvement in the peak VO2 with no worsening of the clinically assessed NYHA class. And for that primary endpoint, this was achieved by 37% of the patients in the mavacamten arm at 30 weeks compared to 17% in the placebo arm. And in that context, about half of patients on mavacamten achieved NYHA class 1. And so the definition of that is without symptoms at 30 weeks compared to only 21% of patients who are receiving placebo. Next slide. This is the NYHA class 1 group. They also did a detailed a collection of patient-reported outcomes. They actually validated a new patient-reported outcome for HCM, but they, according to the Kansas City Cardiomyopathy Questionnaire, which is a very well established, sort of more than 20-year-old patient-reported outcome that's been validated against multiple endpoints. The Mavacamten group had a positive change of 14.9 points versus only 5.4 points for the placebo group. So just in context, KCCQ, the higher numbers are better. So this is a salutary change for Mavacamten. And the minimally clinically important difference for this metric is only 4 to 6 points. So this was a statistically significant difference, but it was also a meaningful difference in terms of its magnitude. And interestingly, when Mavacamten was stopped, patient symptoms, according to this KCCQ PROM, went back to baseline. Next slide, please. In terms of, there were secondary endpoints of the main trial, and what they found was that there were greater reduction in the post-exercise left ventricular outflow tract gradient. And remember, that's very critical for the mechanism of the drug, the purported mechanism of the drug with Mavacamten versus placebo. There was a greater increase in peak VO2 with Mavacamten of 1.4 milliliter per kilogram per minute. The primary endpoint, and this is sort of the elegant outcome, the primary endpoint was concordant with the patient-reported outcomes, this objective physiological endpoint of peak VO2, and as well as the purported mechanism of the drug's action, which is to reduce the left ventricular outflow tract gradient. And these findings were concordant to the prior phase 2 trial, Pioneer, which led to the phase 3 trial. Next slide. In terms of longer term effects, and this is where there's a lot more uncertainty that we'll discuss and was important in the evidence rating, is that of patients in Explorer that received cardiac MRI, there appeared to be salutary benefits in regression in left ventricular mass index and left atrial volumes. And in cardiology, those are mechanistic reasons to believe that there's sort of potentially long-term modeling effects. But despite that, the symptoms, and we discussed this earlier, as reported by the KCCQ, do return to baseline after stopping Mavacamten. So there's a little bit of a discordance conceptually, because the imaging evidence suggests sort of long-term remodeling benefit, but yet the KCCQ returns to normal. So there seems to be some discordance of the patient-reported symptoms and the imaging findings. Next slide. It's also important to remember that the protocol required temporary treatment discontinuation of Mavacamten or placebo for clinical endpoints, including a left ventricular ejection fraction dropping below 50%. This occurred for 3 patients in the Mava group and 2 patients in the placebo group. But in addition, 4 patients all receiving Mavacamten had a left ventricular ejection fraction less than 50% at week 30 at the end of the trial. 3 of those patients recovered with stopping of the drug. 1 patient had persistent low LVEF. It sort of went very low and then went up to 50 after an atrial fibrillation ablation that was complicated. And clinical experts, we discussed this in detail with a number of clinical experts, and there's strong disagreements within the field about the relevance of importance of these findings. Some say it's not important, and others are much more concerned. Next slide. In terms of the evidence for disopyramide, it really is, we really did a deep dive here, and it's overall quite limited. Really short-term studies or small physiological observational studies with cath data, for example. We also, especially from the patients, heard a lot about the practical limitations of disopyramide. There's a national shortage of the long-acting version, so it's very difficult to get. And in terms of evidence, there are definitely no trials that support the use of disopyramide. The best evidence that we have is from a retrospective analysis of 4 centers of excellence. That's at this point 16 years old. Among patients who had symptomatic obstructive hypertrophic cardiomyopathy and were maintained on disopyramide over time, there was a decrease in the mean New York Heart Association class from 2.3 to 1.7. But it's really important to remember that, first of all, these are patients that were chosen to likely tolerate disopyramide better, and that many patients dropped out. So 34% of patients required major interventions like septal ablation or right ventricular pacing. Among those patients, the functional status did not improve while on disopyramide. So there's a tremendous potential issue in this retrospective observational analysis around selection bias. So you're measuring patients who were continuing to take disopyramide as opposed to sort of not doing well on it and taken off it or given a different therapy. And there's unclear external validity because clinicians were choosing who to start on disopyramide. So presumably people, for example, that were more prone to ventricular arrhythmias would not be started on the medication. So overall, relatively weak evidence for the use of disopyramide. Next slide. In terms of alcohol septal ablation and surgical myectomy, there are actually quite a few papers. They're often observational studies from centers of excellence or groups of centers of excellence. And in this systematic literature review, which includes a lot of these papers, there was pooled mean improvement in New York Heart Association class before and after treatment of 1.16 for septal ablation and 1.51 for myectomy. There were large reductions in the median left ventricular outflow tract gradients associated with both procedures in the 70% range. Next slide, please. In terms of harms of the two medications of mavacamten and disopyramide, mavacamten, at least in the trial, was generally well tolerated. Again, there is this controversy where there are disagreements about interpretation of the data about the importance of decreasing left ventricular ejection fraction, and only about 1.6% of the patients discontinued the drug in the intervention group. For disopyramide, there are known contraindications and risks. There's risk of arrhythmia and prolonged QT interval. There's discontinuation due to side effects, most of which are anticholinergic effects, things like dry mouth, constipation, and urinary hesitancy. So in that setting, there are contraindications to use, including things like narrow angle glaucoma, difficult to treat hypertension, and the risk of prostatic hypertrophy. Next slide. In terms of harms of septal reduction therapies, these are taken from the systematic literature review that I reference. Periprocedural adverse ventricular arrhythmias are 2.2% for septal ablation and 1.0 for myectomy. Septal ablation, just to remind you, is a sort of controlled, sort of purposeful myocardial infarction, a heart attack in the area of tissue where you want to reduce the tissue. So it's associated with some degree of ventricular arrhythmia. Periprocedural mortality for this cohort was 1.3% for septal ablation and 2.5% for surgical myectomy. I'll note that this is a very large meta-analysis that has data from trials going back, even the surgeries that went into the papers that were published even went back into the 1960s. So they redid the periprocedural mortality for the more recent era to address this kind of hypothesis. This myectomy probably got better over time. And then in that analysis, the mortality was similar for myectomy versus septal ablation, 1.1% to 1.3%. About 10% of the patients after septal ablation need a pacemaker, and 4% need a pacemaker after surgical myectomy. In terms of reintervention, it's much more common with septal ablation, 7.7% versus 1.6% for myectomy. Next slide. In terms of unpublished or ongoing trials, there are actually a number, and I know some of the trialists are actually here with us today. I just wanted to point out, given the limited time, MAVA-LTE is a long-term extension study meant to assess safety of mavacamten and durability of treatment effect. And we have at least interim results. This is a plan for 5 years, but we have interim results that were presented at ACC this year showing that among the patients with a week 48 assessment, 71% improved by at least one New York Heart Association class, consistent with durability of treatment effect, at least so far as that we can see so far. Next slide, please. In terms of controversies or uncertainties, again, I've referenced there are different disagreements within the field about the importance of these findings of decreased left ventricular ejection fraction. This was, again, Redwood HCM is a different trial of a different myosin inhibitor that we actually just have data that Dr. Maron presented at the Heart Failure Association of America last month, and it happened in one patient, so there's a question about a class effect, but again, really preliminary data. this has been referenced a lot, is that more than 90% of patients in Explorer were white. So there's concerns about the representativeness of the trial population and the external validity in more diverse populations. There are no trials in some very important comparisons that are central to the treatment algorithms and the guidelines with either septal reduction procedures, either procedure or disopyramide. And there's also this discordance between the imaging data from the cardiac MRI substudy in Explorer and the patient-reported outcomes. So there are questions about the durability of treatment effect of mavacamten, particularly when the drug is stopped. And then I'd also say is that there's likely very strong patient preference dependence of therapy options, especially when considering procedures. So these procedures seem to be associated with a good treatment effect, but there's and relatively safe. There's a very small risk of procedural complications, including death, but there is a real risk of death. So that trade-off, different patients are likely to view very differently. Next slide, please. In terms of potential other benefits, contextual considerations, it really is, we again talked to a lot of patients, and it really is striking how patients with symptomatic hypertrophic obstructive cardiomyopathy are often at very important stages of their lives. We heard about people that didn't change their job. They could have gone to a better job, but they didn't want to have an interruption in their insurance. There's a lot of fear about, because given the genetic nature of the disorder, about having families, choices to sort of pursue different types of higher education. There's a lot of patient fear, sort of understandably, about death and the unpredictability of symptoms. The guidelines have shifted over many years to sort of be more permissive towards exercise, but there's a lot of uncertainty about this sudden cardiac death risk, which is obviously very, very, very frightening to patients. Caregivers of patients with HCM report needing to take time off from work, causing financial stress. And then one important, although a little bit controversial point, is that mavacamten, since it's a drug, could provide potentially more access to treatment options at centers of excellence, because the procedures obviously require travel, but it's not, I think it's the reason why this is a bit controversial is it's not clear in real world practice. Is mavacamten also going to be only prescribed at centers of excellence and way this, it doesn't really change equity of access to this highly specialized care that's needed for patients with HCM. Next slide, please. In terms of public comments, we received a number of public comments, and we've posted responses. We've changed the report and made comments publicly, but just a few to pull out. There are a lot of gaps in the data, particularly regarding key comparisons of mavacamten to disopyramide and septal reduction procedures. So we anticipate in real world practice, this will be an incredibly important issue for patients working together with their clinicians, but there are no trials in these spaces. It is important to critically appraise data from trial populations, and we tried to make this clear in the report that that this may look different in the real world, where the populations receiving the drugs are more diverse and potentially many more patients. So you have more statistical power to see different types of effects. And we also received a comment about the safety of initiation of disopyramide at home. This is actually in some ways more an issue for the modeling presentation that you'll hear from Dr. Walton. But long story short is there are data from Canada, from the University of Toronto, demonstrating the relative safety of initiation of disopyramide at home. But we've chosen for the cost effectiveness model to still model the initiation of disopyramide in the hospital, simply because it's referenced in the FDA label and at least in the 2011 guidelines, without being taken back in the 2020 guidelines. Next slide, please. So summary is relative to the usual care. We think that mavacamten improves patient-reported outcomes through the KCCQ, functional status through the NYHA that's estimated by the clinicians taking care of the patients, as well as objective physiological parameters like the peak VO2, and that's concordant with the mechanism that is hypothesized of the drug's action through reduction of the LVOT gradient. It's important, again, to emphasize trials have not been performed to compare mavacamten versus disopyramide. The evidence overall for disopyramide is relatively weak. Trials have not been performed also to compare mavacamten to septal reduction procedures, or for what it's worth, of those procedures, surgical myectomy and alcohol septal ablation, against one another. And we expect, sort of for obvious reasons, that these decisions will be likely very sensitive to the individual priorities and preferences of individual patients. Next slide, please. So in that setting, for the comparison of mavacamten plus usual care, in the setting of a trial that is randomized and sort of the highest standard of causal evidence, measuring a lot of important outcomes and endpoints, including patient-reported outcomes, sort of it was a positive trial, but there's uncertainty about durability of long-term effects and the relevance of this decrease in left ventricular ejection fraction. We issued a promising but insufficient, inconclusive evidence rating. For the comparison of mavacamten against disopyramide, we also issued a promising but inconclusive evidence rating, sort of for different reasons, not so much because of this uncertainty about long-term effects. Actually, disopyramide has been used for decades, and we sort of have a relatively good handle on the safety or side effect profile. But it's more that there's relatively weak evidence for disopyramide, which drove this ranking, and so uncertainty about how these two agents would hold up in a trial against one another. Mavacamten against septal reduction therapies, we did not issue an evidence rating. We can comment a little bit on, again, there's no trial. We can compare from different observational studies, or compare the effect estimate from a trial against observational data. But because of the tremendous preference sensitivity of these likely trade-offs, we did not choose to issue an evidence rating. Next slide. Thank you very much. We'd be delighted to answer any questions that you have.
Well, thank you very much, Jason, for a really terrific presentation. I would ask that our panelists, if they have some questions for Jason or our medical experts, please raise their hand. I see Dr. Murphy.
Sorry. Thanks, Jason. That was an excellent review. With respect to the reduction in LV function, I mean, it's interesting when you think about ACE inhibitors or SGLT2 inhibitors that reduce renal function and yet long-term have huge benefits. So I think it really is very difficult to know which way things will go. You showed a limited amount of long-term data that it sounds like was just presented at ACC. Did that have any data on the effect on LV function, or is that only based on the 30-week endpoint?
Yeah, thank you, Dr. Murphy. I think it takes an endocrinologist to understand some of these issues around the sort of short-term effects and long-term effects. I mean, overall, that is exactly the issue. So some clinical experts who are less concerned about this are saying essentially, this is a myosin inhibitor. It's supposed to be a negative inotrope. It's supposed to do this. So they're less concerned about it. In MAVA-LTE, and again, this is not a paper, as you've referenced, it was an abstract presentation, but there's reference to one patient, I believe, who had, sorry, I'm trying to, yeah, there was one a patient who had a decrease in left ventricular ejection fraction, but it was a little bit, it seems like a little bit, there was a misreading of the left ventricular outflow tract, which affects the dose of mavacamten that they receive. So I think it's not, I would say it's overall not resolved by the data we have so far. Just one patient, and it seems like something else was going on. So I would say, I do think MAVA-LTE will provide evidence for this over the 5 years, but we don't have it yet.
So am I allowed to speak?
Please, we're very interested in your thoughts.
Yeah, so the LTE data, like Dr. Waspi said, there was one patient, and maybe one patient certainly, who had a drop in EF. Majority of these EF drops are transient that get better once the drug washes out. Now, there is some interplay with AFib. If you go into AFib in the context of all these things, HCM and AFib also go hand in hand and quite frequently seen. Then these folks may have a drop in EF. So it gets tricky to distinguish what is driving what in this setting. But so far as, again, to Jason's point, this is still only an abstract, not a peer-reviewed paper, but the data from MAVA LTE is that the EF story is not, or EF is not a major story. And to Dr. Murphy's point, that was just made about the SGLT2 and the kidney function.
Thank you. Dr. Heidenreich.
Yeah, so thank you, Jason, for that great overview. My question was similar to Dr. Murphy's. I think the question for me is, what is the length of time for which we have safety data? Because I think we're all comfortable, at least I am, that there's a clear, fairly strong patient-reported outcome benefit. But the question is, what's the long-term safety data? And so from that ACC or other data, how far out do we have safety data?
Yeah, these are great questions. So the MAVA LT is planned for 5 years, but the interim analysis is 60 weeks. So it is substantially shorter than what we'll eventually get.
Rita, Dr. Redbrick.
Hi, thanks so much. And I wanted to also ask about the ejection fraction, and I know we've had some discussion since I put my hand up, but I was surprised to hear Dr. Waspi say that there's controversy, because I can't think of any time when we think a decline in EF is a good thing. I mean, that is something we monitor for on every, chemotherapy drug, on everything else. That is, in my 35 years of experience in cardiology, we are worried when EF declines, and there were, I believe, 7 total with a decline in EF at different points in that small trial. So I do think, it's an area of concern. The other thing that I wanted to see if you had any thoughts about, in my experience, the patients that I see with hypertrophic cardiomyopathy are, I think of in 2 different groups: the ones that present at a younger age and clearly have the genetic variant with disordered myocardium and have that terrible risk of sudden death due to arrhythmias, which, as you mentioned, is currently being addressed with defibrillators, which don't have randomized controlled trial data in HCM, but are seen from observational data to be successful. But the older population, and probably I think a larger component, although I didn't see that data in Explorer, of the African Americans in particular, are related to people that have uncontrolled hypertension for many years and have hypertrophic cardiomyopathy for that reason, which seems to be a different kind of hypertrophic cardiomyopathy and doesn't carry the same risk of sudden death, although it does have the symptomatic issues that come with having an obstruction in your septum. And I'm wondering, because it looked like from the Explorer trial, most of the benefit of Mavacamten was in that older age group, which I would think is from the perhaps uncontrolled or poorly treated hypertension. And therefore, another way to address it is to have better control of hypertension throughout your lifetime. And it seemed less effective in the endpoints in the younger group, which is the one that I think is the more severe risk of sudden death and other disorders. And I wonder if you had any comments on that.
Yeah, no, thank you for these thoughts. There's a lot of, I know there's a lot of cardiologists on the CTAF asking a lot of good questions. So yeah, Dr. Redbrick, I actually, your reaction, I think, to this low EF thing was sort of my reaction, again, as a cardiologist, initially at least. There really is a spectrum of opinion within the cardiologists who sort of have HCM expertise about this issue. And they really have, I think Dr. Desai sort of articulated the case for not being as worried about it, but there's Dr. Maron and Dr. Oman have an editorial in Circ that kind of articulate more like what you're saying, that they're EFs don't generally go down for good reasons, but this is an area of discordance within the field. And the second part of your question, as I recall, has to do with the genetic issue and the distinction between left ventricular hypertrophy caused by other causes like hypertension. Yeah, this is a tricky issue. I agree. So the diagnosis in HCM is very difficult. My wife is a cardiologist she takes care of elite athletes. Her expertise is in athlete physiology, and a lot of her clinic is trying to figure out if someone has HCM versus athletic heart. And then there's also the variant that you're referencing about hypertension. The trial has very specific criteria for entry, but of note, only about 70% of the patients actually had genetic testing in the trial. So I guess it's conceptually possible that someone could be entered into the trial with having a variant of HCM I should say a variant of ventricular hypertrophy that's unrelated to the gene, although it'll be very difficult, I think, retrospectively to work out that distinction. And I think Dr. Desai wants to add something.
We teed this up nicely for Dr. Maron to make some comments on the left ventricular ejection fraction issue.
Sure.
Martin?
Sure, thank you. So I'll make just a couple brief points about that. The concern, so as Jason was saying, there are lots of experts that have a lot of concern about this aspect of the Mavacamten initiative, for sure. I'm one of them. And here's why. First, you have to sort of break it up into two issues. There's the acute change in ejection fraction that we noted in the trial, the 30-week trial. And then there's the concern about what long-term suppression of systolic function over long periods of time may have in terms of adverse consequences in patients that are on the drug. In terms of the first part, the acute change in EF, Explorer, just to be clear, it was not 7 patients, it was 7% of patients on Mavacamten had a significant drop in ejection fraction, okay? And the magnitude of drop is important here. We're talking about changes of 10, 15, absolute change in ejection fraction of 10, 15, 20% from baseline in a controlled clinical trial environment with expert physicians and expert readers looking at these studies and controlling the change in dose of the drug. That's important. That's an important issue. And why is that? Because there are examples in HCM, not related to Mavacamten, but there are examples in HCM in which patients develop systolic dysfunction, again, from a different mechanism, but we do have some parallels drawn, where adverse events are increased when that happens, okay? So, and we can also draw on other parallels in cardiology where drops in systolic function are often not favorable, okay? So although it was reversible by stopping the drug in the controlled environment, the fact that 7% of patients had significant decreases is a concern, particularly when you consider extrapolating that experience, that clinical trial experience, to the real world, bringing Mavacamten out, if it's approved, into general clinical cardiology practice, where some of the checks and balances and expertise will, for obvious reasons, not be there. So there's a lot of concern about what this low EF could mean in terms of safety if there is broad application of the drug in the US and globally, okay? Two is that we don't have the answer, but of course, long-term suppression of myocardial contractility, and that's what this drug does. It's a powerful drug. Has people concerned about what long-term effects could happen. Could there be promotion of adverse remodeling of the LV, where if eventually you stop the drug, EF doesn't go back up? Or will it promote other adverse changes? We don't know the answer to that, but there's certainly enough precedent, perhaps in other examples in cardiology, where that is a high enough concern as well. So those are the two issues about ejection fraction.
Thanks a lot, Dr. Maron. Dr. Desai, on this issue, you have an additional comment?
Not specifically on this issue, or actually a follow-up comment, a brief one with relation to ejection fraction. To Dr. Marty's point, we can, first of all, there is no long-term data. Proof is always going to be in the long-term pudding here, number one. So completely agree there. Should there be adequate, appropriate concerns raised? Absolutely. I mean, on the flip side, if we go back 20, 30, 40 years to the beta blocker story, we can argue, or we can have conversations about the thought process behind beta blocker in LV dysfunction, which probably when I started my career, when Marty started his career, was just coming of age. Now there's not a single LV dysfunction patient that you would not consider starting carvedilol on under vast majority of the circumstances. So the point here is at this point of time, we just do not have the long-term data to make any assumptions. Rightfully, it is appropriate to put appropriate safeguards, guardrails, to make sure things don't go out of hand. Agreed, but we just do not have the data. Now, the other comment about what I specifically wanted to ask or make a comment about was what Dr. Redbrick mentioned. First and foremost, hypertrophic cardiomyopathy, diagnosis of HCM is not made by genetic testing. Diagnosis of HCM is a combination of clinical plus genetic testing. And typical classic diagnosis is in patients who do not have a secondary cause to explain the degree of hypertrophy seen in an HCM patient. So genetic testing does not make or break the diagnosis. Now, your point, Dr. Redbrick, about hypertensive heart disease of elderly. So I published the largest paper in that just recently, more than 1,100 patients with documented hypertensive heart disease of elderly. That is different from what we characterize as hypertrophic cardiomyopathy based on the definitions that I suggested. Yes, those are slightly different, not slightly, those are very different, mostly elderly. They need, not mostly, yeah, mostly elderly, they need years of uncontrolled hypertension to reach to a stage where they may develop the right amount of basal septal hypertrophy, which then results in a dynamic outflow tract obstruction. That's a different beast. That's a different animal. That's a different patient population. But for
Dr. Desai,
yes.
Dr. Desai, I'd like to be able to have some of our other CTAF members have some opportunities for some quick questions, because I know that our time is short. Lisa Salberg.
Thank you. I just wanted the members of the committee to understand some of the history of the use of Norpace-CR, also known as disopyramide. Over the past decade, there have been on and off shortages and outages of its availability. While patients may have wanted to stay on the long-acting drug, it just was not available, and it's currently on an international outage, which is really unusual. But they would prefer to have an oral medication as opposed to going off to surgery or ablation, as those are much more significant issues. So I just wanted to be clear that it's not that the patients weren't looking for the therapy or they didn't want the option. It was just not available, and it still is not on a consistent basis. And the short acting only lasts for about 6 hours in most patients. So symptoms come back and forth and bounce throughout the day.
Great point, Lisa. Dr. Hawk.
Thank you. Dr. Waspi, thank you very much for your presentation. I had a quick question for you. Your evidence rating was P/I, and I wondered whether you considered a C-, and if so, why you chose the P/I over the C-.
Yeah, no, I appreciate the thoughtful question. You're just to be clear, you're referencing the second comparison, right, with disopyramide? Yeah, no, we did consider that. I mean, it is really tricky, I think, for a number of reasons. One of which Lisa just referenced, which is that we hear this over and over from patients about the issue, the drug shortages, and so the lack of pragmatic access to this, but also the fact that they just really have not been compared in trials. We did think of that as a potential evidence rating. We did, but we ultimately decided against it just because we think that uncertainty is so dominant in this comparison. I mean, this is the basic problem. I mean, just to state this very clearly, doctors and patients will want to know whether this is better than that, and there is no trial. And so the rest of it is all speculation, and and we've done a lot of that, and I think it's reasonable to speculate. You have to make clinical decisions, right? So you have to speculate in the absence of trial evidence, but there really is a lot of uncertainty on that comparison.
Thanks. Dr. Melnikow.
Thanks. I have a question that just goes back to this issue of adverse events. And decline in ejection fraction on mavacamten. So I'm just trying to make sure I understand the numbers here. So I think Dr. Maron said 7% of patients on mavacamten experienced a decline in ejection fraction. And I'm looking at table 8, adverse events, and it doesn't specify what they were. And I'm sort of wondering how that decline in ejection fraction fits into table 8. I only see that there were 2 adverse events that led to discontinuation of the medication. So I'm wondering what happened to those patients who had a decline in ejection fraction. Was the medication stopped and then restarted? Why? So I just like a little more detail on that particular adverse event.
Yeah. So so, and as I recall, and I have to pull this up, there was patient by patient information in the supplementary appendix, which it'll take me a moment to pull up. But then I think part of the issue is also that this happened to some patients in the placebo group. And off the top of my head, I think it's 3 versus 4. Don't quote me on that, I can look it up. In addition to the patients that at the end of the trial had EFs that had gone below 50%. The stopping rule was that if it goes below 50%, you stop the drug. I mean, the drug could have been mavacamten or placebo.
And this was this was the decline in ejection fraction at the end of the 30 weeks. So it wasn't necessarily clear if they continued after that or not, because the trial was over.
No, I'm sorry, I didn't understand the question. The drug was stopped at 30 weeks for the patients. So
Right.
The stopping rule was referent to the patients that had low EF during the trial.
Okay.
But it was stopped anyway at the end of the trial.
Well, thanks for the CTAF questions and the experts' comments. We need to move on, and I'm hoping Dr. Gregory, Dr. Lee, your comments and questions can be entertained at a later time.
Thank you, everyone, for the thoughtful comments.
Hi, I think I'm up next. Can everyone hear me? Okay,
Yep.
so I'm Surrey Walton. I'm a professor at UIC in the Department of Pharmacy Systems, Outcomes, and Policy, and I led the economic modeling team here at UIC. Next slide. So I received assistance from a graduate student here, Jyotimor Sarkar. I also worked relatively closely with Melanie Whittington from ICER. We also got input from the ICER clinical team as well. UIC received financial support for the efforts in forming the model, and otherwise we have no conflicts of interest to disclose. Next slide. So our objective was to estimate the cost effectiveness of mavacamten used along with what we're going to call standard of care, meaning beta blockers and calcium channel blockers. You might call that first line therapy or standard of care. We call it standard of care. And we're comparing that with just standard of care alone. And we're also comparing it to disopyramide with standard of care, myectomy, and septoablation, each with different levels, but still standard of care used with them. Next slide. Next slide. So this is a semi-Markov model. It has age variant mortality in it. It's set in the United States. The base case takes a healthcare sector perspective in terms of looking at costs. The time horizon we use is a lifetime. We discount at 3% both costs and outcomes. We chose a cycle length of 4 weeks to kind of best fit all the data points. So we're going to focus on cost per QALY gained. We also have projections of cost per life year gained, cost per EVLY gained, and then also cost per time spent in NYHA1 class. Next slide. So this just is an overview of how the model works. On the left are the different comparator arms that we have. And the model focuses around NYHA classes. And that's because we have data on treatment effects related to NYHA class. And we also have in HOCM patients a way to tie NYHA class to utilities, as well as to projections of non-drug related costs. So the patients are, enter in at the baseline with a set of NYHA classes, then there's a treatment effect, which I'll go over in detail. And then once that treatment effect is applied, they cycle every 4 weeks, and basically there's an equal mortality rate applied to each of the NYHA classes, and the model just runs until everyone dies and counts up costs and quality of life years. Next slide. So just again, this is meant to be US patients with HOCM. We kind of mimic the Explorer trial. So we have in the model the patients starting at age 58 and all of the comparators, and 41% of them being female. And that's what determines the mortality rate. We use CDC mortality rates for the general population with these demographics. Next slide. So here are the key model assumptions. I want to highlight just first and foremost that all of these cost per quality and cost per life year results that are coming up later are based on a placeholder price of mavacamten of $75,000 per year. So we don't have an actual price, and all the results reflect this placeholder. We estimate patient utilities via NYHA class, and that's because we have information from the Explorer trial on EQ5D utilities from HOCM patients in that trial in each of the NYHA classes. So we felt that was our best evidence-based way to translate treatment effects to quality of life years. We purposely did not vary mortality across NYHA classes, and that was because after talking with clinical experts and looking at the literature, the overall mortality rate of patients with HOCM given treatment is roughly the same as average mortality rates. And also, we didn't see strong enough evidence of mortality differences across treatments from the available evidence. So that is an assumption that we make. Discontinuation is not considered in the model. This was kind of purposeful to focus on the projections of relative value of the different treatment options. We recognize that obviously in the real world, some patients are going to start on standard of care, and then they may choose to get a myectomy or septal ablation. They may after that. There are patients in the trial that had a myectomy and now they're on mavacamten. So this is going to happen, but we're focusing the model on relative value projections. We do consider discontinuation a little bit with disopyramide in the treatment effect later on, but in the model, patients just get in the treatment, have a treatment effect, and then they stay in that arm and experience mortality. So for the mavacamten and standard of care, I have more detail on this coming up. The treatment effect is sort of extrapolated over 8 cycles because there's Explorer data that we had access to going from baseline to week 30, and we're using 4-week cycles. So we take it out to 32 weeks and then kind of freeze it. So wherever you're at after cycle 8, in terms of the relative proportions of patients that are in NYHA class 1, 2, and 3, 4, that relative proportion is frozen, and then equal mortality rates are applied so that they kind of die out. And that's determines the lifetime cycle. That's the time horizon is when enough patients, like 99%, have died. For the myectomy and septal ablation and disopyramide arms, we have literature-based treatment effects based on differential follow-ups, and oftentimes they're long-term, but we have that treatment effect or a way to estimate a treatment effect that's relatively consistent with what we're doing in the other arms. And we take that treatment effect and we apply it in cycle 1. And I'll go into the detail of that coming up as well. So I just want you to understand that we take patients at baseline and then we apply a treatment effect in cycle 1, and then we freeze it in terms of the relative proportions and apply mortality from then on out. So the treatment effects happen quickly, and they're basically assumed to be a lifetime treatment effect. Next slide. So here you can see kind of the numbers we had, the raw numbers that we had to work with from mavacamten from the Explorer trial on top, and then kind of exactly what we did in our model. I'm not showing every cycle here, but you get a sense of we applied a treatment effect at cycle 4. I mean, cycle 4, week 16. That's kind of relatively similar to the week 14 numbers that we had. We had odd data points in there that didn't match up with our cycles, so we had to do some just little extrapolations to make it fit. And you can see the final number that's kind of the most important at cycle 8 for mavacamten. And then those relative proportions, again, are frozen, and the model cycles, and people experience mortality at an equal rate according to CDC, demographic estimates from the United States. Next slide. So this is the exact same idea, but it shows you the numbers that we use for standard of care. So you can see that there are a lower percent of people end up in NYHA class 1 than Mavacamten, and that's reflecting the treatment effect. And this is what we're using to project costs and utilities. Next slide. So for septoablation and myectomy, we have information just on the average percent reduction in average NYHA class, and we have that it's 45%. Again, these are over differential time periods, and we want to be able to compare Mavacamten relative to myectomy in this model. So the way we applied this is we took the Mavacamten number at baseline from the Explorer trial, and then we looked at the proportion of NYHA2 and NYHA3/4 class that Mavacamten experienced in cycle 8. And we took and we held that relative proportion of 2 and 3 constant. And then we increased the percent of patients that were in NYHA class 1 until it equaled a 45% reduction. And so that's how we manifested this treatment effect in the model. We also looked at some other small studies, and sort of the relative percent that we see in NYHA 1 and 2 and 3/4, at least it passes an eyeball test of validity, of similar to what we've seen in some of the little trials. But we base it again on this 45% reduction and holding 2 and 3 relatively fixed again, fixed and then increasing. And then we apply this treatment effect at cycle 1, and again, freeze the proportions and then apply mortality. Next slide. We use these peri-procedural mortality rates for myectomy and septoablation. These reflect sort of a meta-analysis of trials from the years 2000 to the years 2015. So they're a little bit more conservative than the whole study, this whole Redbrick study that included, all the way back to the 60s. So we took the more modern rates seen here. Next slide. So for disopyramide, these are actual patient numbers that we had from this shared paper that we used. And we also know that 34% of patients discontinued disopyramide and went for other options. And so what we did is we used these relative numbers in the initial and follow-up, and we also assumed that the 34% of patients that discontinued had a treatment effect of 0. Okay, and using those two assumptions, we formed the baseline and cycle 1 numbers that you see below. And again, after cycle 1, these numbers are frozen and mortality is applied. Next slide. So here are the cost estimates that are kind of key to the model. Again, we have a placeholder cost for Mavacamten, $75,000 a year. We use metoprolol and verapamil as sort of representative standard of care treatments just to apply costs there. We have an annual cost of disopyramide, and then we also have, based on literature, that in the US, patients often experience a hospitalization when they're starting disopyramide. So we applied that to the disopyramide arm. You can see the procedure costs here that we use for myectomy and septal ablation. There's echocardiogram costs. And then we have estimates of non-drug costs that are tied to NYHA health states. The NYHA 1 and NYHA 2 come from numbers provided to us by BMS based on a study of private payer costs. And to get from 2 to 3, we used the relative proportion of costs seen in heart failure between state 3, 4, and 2, and just applied that to that 2000 number. So that's how we got all these numbers. Next slide. So here are the utilities by NYHA class. And again, these are EQ5D utilities of actual HOCM patients in the Explorer trial. We used the utility across classes from the Mavacamten patients in the Mavacamten arm. We used the standard of care utilities in the standard of care arm, and we took the average and used that for the comparators. one could make, these are coming from a clinical trial. They are actual HOCM patients, so they're not heart failure patients, and we like that. They are capturing perhaps adverse events and side effects associated with these two drugs, and then we're using an average and applying it to, say, disopyramide and myectomy. So there could be some error there, up or down, but they are associated with NYHA class, and they are coming from HOCM patients. We also apply a slight disutility by age in the model. Next slide. So we have some disutilities that we apply in the model too. So we take account that there's pacemaker use in septal ablation and myectomy, and it's differential. And we apply this lifetime disutility of septal ablation that's coming from the literature. We also have a procedural disutility of septal ablation that's 1 cycle. And then we have a larger disutility that's applied for 6 cycles. The septal ablation one is kind of based on a stent disutility, and the myectomy is based on a relative disutility of CABG surgery versus stent. And and it's from a study that kind of estimated this across time in patients, and they basically got that this disutility lasts about 6 months. So we applied this disutility for 6 cycles. Next slide. And we're now to the results. So here you can see for each of the comparator arms, the total drug cost, the total cost, the QALYs, the life years, and the years spent in NYHA1. And then the EVLY, which doesn't always apply here, but it's basically equal to the QALYs here because the life expectancy is the same. Next slide. So these are sort of the key results in the base case. These are the incremental cost per QALY gained. So relative to standard treatment alone, Mavacamten and standard treatment, again, at this placeholder cost of $75,000 per year, you get a very high 1.2 million per QALY gained. Disopyramide is an even higher cost per QALY gain with that comparison. Myectomy and septal ablation both cost less and provide more QALYs. So Mavacamten is technically dominated by them. You do get a little bit, there's no life year difference between standard treatment and disopyramide because of the mortality assumption that we made. Because of the paraprocedural mortality used for myectomy and septal ablation, there are very slight life year differences. You see very high cost per life year gained of Mavacamten relative to them. And myectomy and septal ablation dominate in sort of in all the different ways you can measure it. If you do look at cost per additional NYHA1 per year, it's $219,000 for standard treatment and $278,000 for disopyramide. Next slide. So the incremental cost effectiveness ratios in the one-way sensitivity analysis become negative and get very large because of crossovers in 0, and because there's certain inputs where Mavacamten's dominated by standard of care, and it shifts to being a relatively high incremental cost. So we split up the one-way sensitivity analysis into cost and QALYs. I think it's easier to present this way. Because there's a lot of costs per year, and it's a lifetime model, the discount rate for costs ends up having a big effect on the costs. You can see after that, the Mavacamten treatment effect. So increasing or decreasing by a percentage-wise, the treatment effect in Mavacamten, has a relatively high impact on costs. You see overall, though, that the incremental costs are big over all of these kind of changes in the one-way sensitivity analysis. Next slide. And these are the incremental QALY differences, and the utilities that you've put into the NYHA classes have relatively the biggest effect on these numbers. And it ranges from Mavacamten being dominated to Mavacamten producing more QALYs. When you put these two things together in these sensitivity analyses, the incremental cost per QALY is always very large. Next slide. So we took here, we create distributions to reflect variance in the potential outputs, and we run simulations, and each simulation takes a value for the inputs from each of their respective distributions that can all vary up and down. And we run this 10,000 times, and we look and see how many times in these simulations was mavacamten found to be cost-effective relative to standard of care at these various threshold points. And we get that in none of the times, so 0 of the 10,000 simulations is it cost-effective at these rates at this placeholder cost of 75,000. Next slide. So here we did a scenario analysis where we did have different mortality for patients in NYHA 3-4. We used a all-cause death hazard ratio of 1.96 that we got from the literature. And so in this scenario, the patients in NYHA class 3-4, had basically twice the mortality rate as in 1 and 2. If we run it with that in there, this is the results. You still get the cost per quality gain of mavacamten relative standard treatment being quite high. It's lower than in the base case, but it's still quite high. It's higher in disopyramide than it is in standard treatment. It's very high cost per life year gained, comparing mavacamten to these comparator arms. You can see the cost per EVLY gained in this scenario, and very similar cost per additional NYHA year 1. And
Dr. Walton, I'm hoping you're wrapping up shortly.
Yes, the next one. Next slide. Here, because we didn't have a formal modified societal scenario, we took and made employment be 100% in NYHA 1 and 0 in 2 and 3-4. And we used an average wage rate, and we reran the model. And then that's in the top row. And in the bottom row, we made mavacamten be associated with full employment in all the NYHA classes, and standard of care be associated with 0, just to rerun to get a potential variance from a modified societal perspective. And even in the kind of the very extreme case, we get a cost per quality gain of 242,000 at that 75,000 placeholder cost. Next slide. So we use a placeholder price. We don't have long-term data beyond 30 weeks. There is a lack of evidence on direct comparisons between myectomy and septal ablation. The utility scores are coming from the Explorer trial. The evidence for myectomy, septal ablation, disopyramide are coming from observational studies, whereas for mavacamten and standard care, it's coming from a clinical trial. There's an absence of data on societal costs of HOCM. And there's heterogeneity in HOCM patients that's not addressed in the model. Next slide. The comments we received were that NYHA classes do not capture day-to-day utility adequately. A societal perspective should have been used. NYHA classes are in fact related to mortality. There's variability by gender and race in patient outcomes, and the model does not include discontinuation and adverse events. It kind of talked about, why we did these things. We recognize that there's variance in utility in patients, probably in all these treatment arms that's not captured by the NYHA classes. But again, the focus of the model was to get a projection of average value of one treatment versus another. We did try to explore variance of potential variance if we had been able to include a societal perspective. We did a scenario where we had NYHA class associated with mortality. And we didn't have enough data or didn't see enough data to address these other comments. Next slide. So actual cost effectiveness of mavacamten will depend on its actual price. At the placeholder price, the incremental cost per quality are very high, above standard thresholds. It's even higher with disopyramide. Mavacamten is dominated by myectomy and septal ablation at the placeholder price. And the sensitivity and scenario analyses suggest that these findings are very robust, again, at this placeholder price. So that's it. So I'm happy to take questions.
Dr. Walton, thank you for that tour de force. I think we've left us about 10, 15 minutes of questions. Dr. Phillips.
Yes, thank you very much. Price. So you didn't have a price. How did you come up with the price that you used? And did you look to see what the price would need to be in order for it to meet the typical threshold?
So yeah, so the price came from like a Google search of some financial consultant being asked what they thought mavacamten would be. So it is very much just a placeholder price that reflects somebody's opinion of what it might be. And because BMS is not discussing any kinds of price information, that's sort of what we're relegated to, is what can we find out there that's the best guess by somebody with some expertise. But it really is just a placeholder price, and that's why I keep saying it over and over again about that. We do calculate value-based prices, and I believe it's about $12,000 a year. To get an exact number, I'd have to go read the report. That's in the report, I promise you. But so I think that's right. Yeah, we definitely do calculate that.
All right, thank you very much.
Yeah.
Dr. Hotch.
Thank you, Suri, for that presentation and great modeling work. I wondered if you could show us slide 57.
I'm sure someone can put it up there.
So on slide 57, there are going to be some columns, and one column is called life years. That's kind of on the right.
Yes.
Just wanted to ask you 2 clarification questions before eventually I get to my question about 3 hours later. I'm looking at the life years column.
Yeah.
Am I right to interpret the first 3 rows as saying that with the model, Mavacamten standard treatment and disopyramide have according to the model, they have the same expected amount of life years?
Yeah, these are discounted life years.
Okay.
Projected from the model. And so on purpose, we purposely did not have mortality vary by NYHA class in the model. So we didn't think there was enough data out there to suggest that there would be a mortality impact of Mavacamten and standard of treatment relative to standard treatment alone or relative to disopyramide. We also don't have differential mortality other than the paraprocedural mortality of Mavacamten relative to septal ablation or myectomy. Myectomy and septal ablation get associated with very slightly fewer life years because of this 1% mortality rate that's happening in cycle 1.
So if I'm willing to go along with the assumptions you made in the model, and let's say I was only focused on life years, not the cost, just life years, I would say more or less the message coming from this construction of the evidence is that those 3 options have more or less the same amount of health benefit measured as life years.
That's correct. That's an assumption in the model. Yeah.
Follow-up question, same idea. In the qualities column, and I look at the highest ones, it looks like it's 14.97 on the last 2 rows.
Right.
Same sort of thing. If I believe the assumptions of the model based on the evidence and what you did, I would say the 2 options that give me the highest amount of quality adjusted life years are the septal ablation and the myectomy. Is that right?
That's right.
Okay, and then finally to my question, the people reviewing the clinical evidence might have given a P/I rating to certain things. Is there a reason why you feel that maybe just looking at the trial gives us maybe a different sense from looking at the model? Is there an easy way to understand? Or maybe it's telling me the same thing.
I don't know exactly how to answer that. I mean, the P versus I is sort of a clinical opinion about the evidence base, behind this. Obviously, we are taking, I tried to talk about this in the limitations. We're taking a trial based on 30 weeks and kind of presuming a lifetime impact from that. And we're also comparing data from a clinical trial on the treatment effects versus real world results on different patient populations and comparing them as if they're the same and as if all that evidence is exactly the same. This is a model. So, take all of this with some uncertainty and maybe with the same idea of, potential uncertainty in the evidence base and the findings. So I wasn't asked to put a rating of PI on this, but, I think I would put the same kind of rating on this.
Super. Thank you so much, Suri.
Jeff, this is David. I just wanted to jump in. Specifically, what you just highlighted is directly connected to why the clinical team didn't put an evidence rating on Mavacamten versus the procedures. So Mavacamten produced more life years than the procedures, but fewer qualities than the procedures. And those lost life years happen right away. right, with the procedures. Because if you get the procedure today, you have a chance, a 1% chance of being dead in the next few weeks. And given that, given this trade-off between long-term quality gains and short-term risk of death, we felt that putting an evidence rating on that rather than letting patients and their providers decide was very difficult.
This is Ralph Brindis. I wanted to thank Dr. Waspi and also Dr. Menikow, who looked at Dr. Walton's work and pointed out that a price of $9,600 would achieve an ICER of $50,000 to $12,500 to achieve $100,000 per quality, and $15,400 to achieve $150,000 per quality. Lisa Salberg.
Thank you for the opportunity to comment here. And I'm a little dumbfounded with the methods that are used here. Assuming that the life effectiveness is going to be the same for all of the treatment arms, it's just not real world. It's not even close to real world. And it's disappointing to see it painted with such a brush that it is not real. And I'm going to ask both Dr. Maron and Desai to talk about assumed lifetime effects being consistent through the New York Heart Association class through the patient's entire life post any procedure or therapy. But if you were to use this theory in real world, you would find that maybe it hits for 8 to 10% of the population. It's not real world. And I'm very concerned that the committee is going to misunderstand disease progression in HCM. Dr. Maron, Dr. Desai.
Thank you, Lisa. And Dr. Desai, you get to respond.
So I agree with Lisa. NYHA class 1 is not the same as NYHA class 4. And, under any circumstances, that should also include economic analysis. The other aspect is the reality, some assumptions about the mortality rate of myectomy versus alcohol ablation, et cetera. The 1%, that's unfortunately an aggregate in a meta-analysis. There is published papers that have suggested the mortality rate in experienced centers of excellence where these procedures need to have been done to be close to 0.5% versus not centers of excellence where it is reaching 6% in terms of mortality. So that's one point I'm going to try to make is it is not 1%. Assumptions matter, number one. Number two, the other aspect is availability. And I was going to reserve that to when I present my public comments is per year in the US of A, about 1,500-ish myectomies are done, of which the centers that do more than 100, 150 is about 3 or 4. The rest of it is done in places that do less than 10 of these a year. So again, the business of 0.5% versus 6% mortality comes into play. So there are simply not enough proceduralists available on the planet to be able to cater to everything that is asked of them. I'll probably stop there in the interest of time. And I want Marty's opinion also.
Well, you really gave a good argument for the creation of a registry related to septal ablation and myomectomy. I will say that. Dr. Redbrick.
Okay, I'm unmuted. Thanks so much. I just wanted, because we're talking a lot about NYHA class, and I realized, it's a bit subjective and it wasn't clear to me how NYHA class was determined in the Explorer trial. It means, as we know, a slight limitation, and I wouldn't say there's a lot of inter-observer standardization on what we call NYHA class 2, but how was it determined?
I don't know exactly how it was determined.
So am I allowed to say, as I'm leading the next trial in the similar vein, the Valor HCM, so again, I did not participate in the Explorer HCM, but it is physician determined, the physician who is recruiting the patient. And at least in the Valor trial, what we are expecting is the same person try to determine NYHA class through various time points. Now, how much of a strict adherence there was to that, I cannot answer that question specifically, but it is a physician determined NYHA class.
And I just wanted to make Ralph a quick comment. Can I just, Ralph, sorry, but I went back to Explorer. It was 7 patients on Mavacamten that developed EF less than 50% in the trial. So that is what it says.
I was wondering if Dr. Maron would comment. I also want to acknowledge the important use of PROMs used in these studies and how I find them particularly helpful. Patient-reported outcomes versus physician assessments. And
absolutely.
Dr. Maron?
Sure, thank you. So, as we were saying, assumptions are important. So here, here's just a few comments. First, that there is just no question that today that mortality for myectomy and alcohol ablation in experienced centers is incredibly low. It's 0.5%. And we know that long-term improvement is stable and consistent over long periods of time after these procedures. You got to remember, we've got almost 50 years of experience with surgical myectomy. Okay, so the argument that there's no, prospective clinical trials with surgery, it just doesn't hold up, because you've got enough single center prospective data to say that these procedures are highly effective. We call them high efficacy, low risk procedures for patients. That's huge. And in the context of cost, that cost analysis just blew me away. I mean, with all the assumptions I get, with this way this whole thing started with rising healthcare costs, it just doesn't make sense to me. This Mavacamten is priced, even if you accept that there may be changes to that price, does not fit the clinical value here. It just doesn't connect up. You want to use dominated, whatever adjective you want to use, it doesn't hold up when you compare it to the invasive procedures. That is why there is an argument, I'll finish by just saying, that is why the argument is strong here for why there should be a net, a rating here of C- for this, because that is justified based on everything we've just said.
And the final comment goes to David Rind.
Thanks. I actually wanted to ask Lisa, I wasn't totally sure what you were worrying, what direction you thought the model was going to get it wrong because of not looking at progression of disease over time. Are you worrying that we're overstating the value of Mavacamten compared to the procedures, because the procedures over the long term, you tend not to progress, and we don't know that on Mavacamten you don't continue to progress? Or were you worried about something else?
I think my worry starts with the word assumptions, and they're too broad. I know many myectomy patients who've moved on to heart transplantation. I would not call that static or consistent in a particular class. I think there could have been more sensitivity used to break down actual percentages of who's moving on to what class. And I don't necessarily know, because I'm not an economic modeling expert, whether this is going to favor one side or the other, but I know it's not accurate. So I just want to be as accurate and forthcoming as possible to explain that this is a highly variable disease. You can think somebody is stable for a long period of time, and then they move into a serious bout of heart failure, which may have very expensive therapies on that side. So I want to understand, I want everybody to understand, this is a complex disease process that doesn't have a pathway for a patient. There are multiple things that could happen in the life of an HCM patient that may or may not benefit from Mavacamten. We're still early in process to learn what the value will be.
Dr. Gregory, you're on. Last question.
Great, thank you. I guess I want to understand if this were approved tomorrow, would it be hierarchically used or used in place of disopramide or used before surgery?
Kim, because that's such a great question, we need more time to address it in the policy roundtable. All right,
Got it.
sorry, but it is a great question.
I guess.
Could I say one final word just on the econ model versus sort of individual patient experiences? It is certainly true that there's going to be individual variance. There's going to be variance across where you get care. There's going to be variance across age and time in any individual patient experience. And the model is not designed to capture that. It's not in the scope of the model to capture that. The model is trying to say for a health system, on average, if I use one treatment versus another, what is a value-based price? And so these utilities are average, and we do freeze the treatment effect and hold it constant across time. If there's sort of natural deterioration across NYHA classes that happens across time, it's going to very likely be the same across these treatments, and the incremental results are going to be similar. So that's just trying to talk about what the model is trying to do versus patient experience. And they're both very important considerations. And I don't pretend that NYHA class average scores would reflect the variance in an individual, any one individual across time. That's a different question. So
Well,
anyway,
thank you very much, Dr. Walton. We're running a little before time, and I think it's very important for us to be able to hear our public comments at this time.